Wow, the recording is in progress. So hopefully everybody can see my screen. Dr. Rojas wanted me to announce this. We're always happy to announce stuff for other groups that are doing educational work. And so on December the 8th, Parents Helping Parents, which is a very good organization, and the Citizen Potawatomi are going to host a seminar for family members who have someone who has an addiction problem. So they'll talk about the understanding the nature of addiction, how it affects family members, how you can help or not help your loved one who has some addiction problem, and realize that recovery happens both for the individual who's suffering with the substance abuse problem and for the family as well. So understanding my part in helping my loved one begin recovery, that'll be there at the Citizen Potawatomi. I think that's there in Shawnee, and it'll be co-sponsored with Parents Helping Parents, 7 p.m. So if you want that flyer, you can get a hold of Kelsey, and she can send it to you, or you can contact Citizen Potawatomi. Let's see, I don't think he put a contact information on there, but so anyway, I wanted you all to see that, and then I wanted to show you what's coming up in November. So I'll do the second piece today on substance abuse counseling and ethics. Erin Coos will be with us next week. You know, that's Veterans Day. She works for the VA, and she's off. It's a federal holiday. She's graciously agreed to give us a talk on the Veterans Administration, Veterans and Substance Abuse Services. So she works over there in Substance Abuse Clinic. So we look forward to that next week on the 11th on Veterans Day. On the 18th, Dr. Whisker is going to talk to us. We don't have this filled out in the program here, but we will not too long. But he's going to talk about substance use and the neuroscience of addiction. So that'll be one you want to look up and see, because he'll explain the neurophysiology of addiction. So that's always an important kind of thing to know when you're working with families and you're working with substance abusers. Then we won't have anything on Thanksgiving. So that's what we've got. We haven't gotten it all filled in, but I'm just letting you know that Erin's going to be here to talk about veteran substance abuse program in the VA. Dr. Wizard's going to talk about the neurobiology of addiction. So I look forward to that. So now we'll go over here and start what we'll talk about today, which is going to be ethics, compliance, and substance abuse counseling. And we'll try to talk about all three of those and see how they're interrelated and how law, ethics, compliance, and quality are all an important part of our clinical practice. So we'll compare and contrast. Hey, Vicki. We'll compare and contrast compliance and ethical principles and how those two programs work together. I'll try to look at the relationship between those two. We'll take a look at the 7 elements of an effective compliance program. And I should say that, we're talking about usually, if we're at a big institution, you think about the compliance program being something that somebody else does to you, and that may be the case if you're working in a large organization. But if you have your own independent private practice, you have a small practice, compliance is still something you ought to look at, and particularly with the way we use technology in practice today. Being able to have an effective compliance program, even if you're just one or two or a small community agency, is important. And knowing how ethics, quality, and legal aspects kind of come into that. So that's what we're going to do. So a couple of definitions. So ethics are these kind of values that we have about how people should treat each other, how society should treat us. And then when you get into professional kinds of things, it's how a professional ought to treat other folks, how they ought to treat their patients, how they ought to treat their clients, how one business ought to interact with another one. And so that's really what we're talking about, is these moral principles. Then they get applied to professional practice, they get applied to individual behavior, those kind of things. So these are the moral principles in a lot of ways that undergird everything we do. Quality, we'll take a look at that. And quality is really how you measure excellence, or how you measure effectiveness, or how you measure getting better. And so quality is an important part. And I would say that good professional ethics support quality. So we want to know, in healthcare, is it safe, and is it effective, and is it evidence-based? Is one way we would talk about quality, is the treatment evidence-based. So let's see here. And then compliance are the kinds of things we do, the programs we have in place. And like I said, if you're in a big organization, these are very sophisticated, cost a lot of money kind of programs to make sure that things stay compliant. If you're in a small agency or an individual practice, there can be some kind of simple things that you should be aware of, and things you should do to ensure that professional, ethical, legal, and quality standards are being met. And generally we think about, compliance programs or primary goals being keeping you out of jail, or keeping you having from regulatory compliance problems. But a good compliance program also helps you remain ethical, and it helps you, if you do it right, and ensure some quality. And then laws are the things that are established for the good of the community, in public health and in healthcare. These have to do with not taking advantage of people, that it be, the treatment be effective, it'd be safe, that we have a responsibility to folks to take care of them, make sure they're safe. We don't provide treatments that are harm to other folks. And so certain laws, certain responsibilities we have to patients. And so that's what the laws have to do. So there's really civil law, criminal law, and regulatory law that we'll take a look at quickly. So if we stack it all up, this is kind of how it comes together. And you can see there's more starch in it the further up you go, in terms of, you move from kind of aspirational to things that really cost you up here with criminal law. But professional organization with aspirational goals. So these could be kind of things like, I'm trying to think of something, maybe like, the Southwest or the American, psychotherapy organization or psychotherapy group association. They have some aspirational codes that they like you to hold to, like how you would do group, or how you would do psychodrama, or how you do those kind of things. And you hold to those kind of aspirational codes. And then professional education accrediting bodies. This is like CSWE. This is like ACA. This is like APA. These indirectly affect practice, but they have some pretty strong teeth. And so you want your program to be CSWE, Council of Social Work Education accredited, American Psychological Association, ACA accredited, those kind of things. And so these professional educational accrediting bodies, they ensure that you're teaching certain kinds of things. Those certain kinds of things that you're being taught are being taught by people who supposedly really know what they're teaching and have the right background education and training to be able to teach those. They talk about how much practical experience, that a person gets, those kind of things. And so those professional education accrediting bodies are very important, and to ensure that folks who are coming out of an APA approved program, a CSWE accredited program, ACA accredited program, that they meet their education and experience meets, pretty much it's a minimal standard, but it meets a minimal standard that a group of professionals have decided is important. So that's an important piece. It's lower down here on the pyramid, but it supports all the practice. Then you got provider certification codes and bodies. And so these are going to be like organizations that, you go through a process to OSA, Oncology Social Work Association would be one where you're going to go through and you're going to get certified. They have some codes about how you treat people who have cancer and those kind of things. And so these are certifications. They carry some weight and they have some codes that you're expected to do. Usually these are kind of specialty areas. And then you have the professional organizations with mandatory codes. This would be like NASW, APA, those kind of things. And so there's a mandatory code. And if you violate that professional mandatory code, you can be turned into the ethics committee, and the ethics committee can do an investigation. They don't touch your license, but they could, kick you out of APA, kick you out of NASW, those kind of things. So that would not, it doesn't really hamper your ability to work, but it certainly is a slap on the wrist or a clear notification that you're practicing poorly. And then you have agency and institutional certifications. These are going to be like a Joint Commission. These are going to be like, what is it, CARF accreditation. So these are basically say your organization is meeting certain standards in terms of kind of professionals you have, that it's a safe place to go to. You got proper fire extinguishers, those kind of things, that you have the right kind of supervision, that you're billing right, that you have the right kind of professionals in place. And so and these are important too, because a lot of payers link to CARF accreditation, Joint Commission accreditation, state level accreditation for community mental health center, those kind of things. So having your agency and institution properly certified and accredited is certainly important. And then you move up just a notch is where you're going to be state accredited. So here, to be licensed, or you need to be certified by the Oklahoma Department of Mental Health and Substance Abuse Services, or those kind of things. Or, if you're going to be contracted with Oklahoma Department of Mental Health and Substance Abuse Services to see their patients, and you're going to have to meet certain kinds of standards. So you also think here, we said state agencies, but Sooner Care would be another one. Medicare would be kind of another one that you would want to make sure you had, and these are directly related to or tied to being able to get reimbursement. And then what most of us think of are state professional licenses and codes. And so these are kind of things like your licensed barber or hairdresser or plumber, or your licensed social worker, your licensed alcohol and drug abuse counselor, licensed psychologist, those kind of things. And so this is really where if somebody has a grievance against you, they file a complaint with the board. The board actually has a ethics committee. They do an investigation, sometimes a very extensive investigation, very painful investigations, where you get your lawyer involved if you need to, and they can sanction your license. And when they sanction your license, then it inhibits your ability to make a living. So nurses and physicians and social work psychologists, counselors, the whole bit, are very sensitive to having somebody mess with your license, because that's your livelihood. And then you have regulatory law. These are really going to be things like we'll talk about these in a minute, but Medicare, Medicaid, regulatory laws that you could really get in trouble with if you violate those laws. Usually have mostly to do with billing, and they have to do with collections and those kinds of things. But and what you can do with those are state level, what you can do with your license. But these would be state and probably national regulatory rules and laws that we would have to comply with. We'll talk about Medicare here in a minute. And then you got civil law, and we'll talk about that. And civil law really is just, it's not criminal. You didn't commit a crime, but you had a duty to somebody through your profession or through your relationship with them, and you failed to uphold that relationship, and so you're negligent. And the preponderance of evidence is lower here than for criminal laws. It just got to be it's preponderance, basically, is what they say. And so that means that it looks like everything's kind of shifts, that you made some or somebody made some kind of mistake. And then you got criminal law, where you're going to put you in jail. They're going to really take some stuff away from you. And here it's got to be, beyond a reasonable doubt. So here you got to be pretty well sure that, that you can't account for whatever happened any other way. And so criminal law can really take a bite out, because it puts you in jail. And of course, you'd lose your ability to work and those kind of things. But criminal law, we try to avoid that as much as possible. So this is kind of how the ethical compliance, kind of quality comes into play here, because if you're providing quality care, then you're less likely to have some problems with these codes and these boards and regulatory laws. So this is kind of the way it stacks up from the bottom up to the top. We can look at it a little differently, and we can say that ethics is kind of the core. And so, there's, we'll look at this in a minute, but, ethical principles, every discipline usually has a handful of ethical principles that everything rides on. And then you have ethical standards. And generally speaking, if you use a little bit of common sense and you stick with the ethics, then it's going to help ensure that you're providing quality care. And we'd even say evidence-based care. And if you're providing evidence-based care, then there's a good chance you're going to be complying with the laws and regulations, and then you're going to be compliant with the law. So this is kind of the way it stacks up. So this is why we start with ethics, or we're not going to start with ethics today, but this is why ethics is such the central piece of our three tiers of quality here. So I wanted to look at, because the ethics lecture ought to look at the ethical codes. So at least look at them and know where they are. So we're going to go through here and do this. So this is the Oklahoma LADC code. And you can see these are kind of the major categories. It's a pretty, let's see here. Can you see that? Do you see the codes? Can you see them? No? Yep. Lenore?
Yeah, I can see them, but the page just came up for the Oklahoma State Licensure Board.
That's what we're looking for.
Okay.
So we were going to look down here and see where's laws and requirements, code of ethics. There we are. So you can see this is for the LADC. This is it. But we can look on here and see. So, your primary goal is recovery for his clients and his family. So that's what we're talking about here. Use evidence. I show evidence genuine interest. So you're talking about interest in those, and maintain an objective view. So these are kind of really operationalized and straightforward. I'll recognize this when the best terms of conduct to release them or to refer them. I shall adhere to the professional rules of confidentiality. So you got that in there. I won't discriminate. I shall respect the rights of others, advocate for public policies and legislation that support substance use. So I'm committed to assess my own personal strengths and limitations. So this is a one-pager that's pretty straightforward and pretty well just operationalized as, I will, or I have commitment to, I shall cooperate with duly constituted professional ethics boards, promptly compliant, and all those kind of things. So this is a pretty straightforward. This, what is there, 10 things here, I think, or 12? And you just sign it, print your name, sign it. But this is the way they've gone about structuring their code of ethics. Like I said, so LAD is pretty straightforward and pretty well operationalized. So then if we want to move on, look at social work, and we get a little bit more involved here. Let's see if we can get this one to come up. There we go. So I'm just looking at the one that's, they've just revised this recently. So I'm just going to look here at the website here. But you can see now social work and psychology both have this, but they have these kind of GERDI underlying principles. So the foundation of these unique purposes is predicted. So these are the core values that they would say in social work. So service, social justice, dignity and worth of the person, importance of human relations, integrity and competence. So you can see you got duty to the patient, you got duty to society, and duty to be competent. So they break it down this way, and then they'll explain those ethic principles. The value of service is ethical for social workers. Primary goal is to help people in need. and to address social problems and a little bit more discussion. And social workers challenge injustice. And they respect the inherent dignity and worth of the person. So you can see that they have these, and then they drop down, and then they'll have the standards. This is the way most codes work, is you have some principles and you have these standards. And so they've broken down, social work's broken down their standards to responsibility to the client or the patient. So and they have these comments or these statements about commitment, self-determination. Look at this. This is quite a bit on informed consent.
A lot on informed consent.
Yep. And so in your practice, you might want to ask yourself, do I give proper informed consent? And you can see here, a social worker should discuss with the patients the social worker's policies concerning use of technology. And so there's a whole section here about technology, something about videoing. Social workers should provide services to clients only in the context of professional relationship. Clients that are not literate or have difficulty understanding primary language used in the practice setting, social workers should take steps to ensure of the client's comprehension. Make sure they have capacity. They're going to talk about what social workers need to do to be competent. They're going to talk about what they need to do to be so culturally competent, conflict of interest, privacy, confidentiality, quite a bit there, access to records. Then we have sexual relationships, physical contact. So all of these kind of things, some specific information about payment. So this is, then there's the section on colleagues. What's your responsibility to your colleagues? Respect, dispute involving a colleague, sexual relations. Social workers who function as a supervisor or educator should not engage in sexual activity or contact, including blah, 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 with supervisees, students, trainees, or other colleagues over whom they exercise professional authority. So there you go. What do you do if you have an impaired colleague? Incompetence of a colleague. So all of these kind of things be good to have some visibility on. So then you got ethical responsibilities as professionals in your practice setting. So all of these are kinds of things that you'd want to take a look at. And it's interesting how different professions stress different kinds of things. So you can see that there's, for most social workers, MSWs, you don't see much in here about education. But if we move over here to American Psychological Association, we can see how they lay it out. So here it is. This is the website. They've got a preamble. Then they got these general principles, very, very similar to social work. They got benefits and non-maleficence. And so this is, you're going to do no harm, and you're going to try to do what's in the best interest of the patient. You have fidelity and responsibility. So it's important to establish this trusting relationship. Nice statement about that in terms of trusting relationships. You're going to have integrity. You're going to promote honesty, truthfulness, justice. Sounds a little bit like social justice with social workers, dignity and respect, all of those kind of things. But then when you look down here, so if you were an educator, you're doing education as a social worker, you might want to look at APA's ethics for education. So they talk about description of educating and training programs. You need to teach stuff that's accurate. You don't need to ensure that what you're saying, what you're promoting is reasonably accurate and supported by research and evidence-based, those kind of things. So they'll talk some about group therapy. So these are just the different kinds of things. Some social workers might be involved in assessment. So it might be good to look at what APA says about assessments, the use of assessments, informed consent about the assessment. So it's good to take a look at different, at different professions, because different professions do different kind of things here and there. And so, and sometimes you may find yourself doing education and training, or you might find yourself doing more teaching, or you might find yourself doing more research and those kind of things. And so it would be good to see what other professions who are engaged in those kind of activities might think about it, or what they might say. And then we'll look at the American Counseling Association. They have theirs little different format. But we'll take a quick look here. So they've got a general purpose, and they got their preamble and those kind of things. And then they take a look at things like the counseling relationship, confidentiality. They have a good section of working with other professionals, supervision and training. They talk about that, research publications they'd be involved in. And they're one that has a section dedicated to distance counseling technology and social media. So if you're a social worker, psychologist, and you're thinking about social media or using technology, you might want to take a look at what the ACA has to say about it, just to kind of be up with it. But anyway, they're generally laid out the same, but the different codes emphasize different things here and there. So being a session on ethics, we wanted to make sure that we at least looked at the codes. Now, then what we don't think as much about when we're talking about ethics is we're talking about quality. And, what I would say is ethical practice is quality practice. That, those two are not separated. That if you're going to be ethical, you're going to provide quality, and it's probably going to be evidence-based. So we're going to take a look at 3 different kind of ways to look at quality. You can research these if you want to. But this is the Agency for Healthcare Research and Quality. And so they're going to say that there's 6 domains of quality healthcare, and it's got to be safe. So it's intended to help. It's not intended to harm. Generally, the work that we do is that every once in a while you hear somebody doing something that's not safe. Years ago, holding, and then they would hold kids in blankets, and a couple of kids smothered and died. So you'd say, well, that's definitely not safe. And then effective is that there's some, service, there's scientific knowledge that supports what we're doing. So you can go to the literature and you can see that there's been some research. Hopefully it's been, randomized controlled trials, or it's been some, quantitative analysis, that there have been a number of studies that have confirmed basically the same kinds of outcomes, that you're pretty sure what the curative factors in the treatment are. And there's some generally describable way to deliver it. I mean, so it's not just willy-nilly. That doesn't necessarily mean you got to use the manual and exact protocol, but you don't want to do trauma working for you. You're pretty sure that they know how to soothe themselves and take care of themselves and be safe. So you don't just jump in doing trauma work for you. You've established a basis for those skills. So these would be the kind of things we're talking about. We're talking about effective. And it's patient-centered. In other words, it's respectful of the patient's values, the patient's thinking, those kind of things. And so understanding the patient, it's timely, in that it's not what they say, it just goes on and on. I mean, it can go on and on, but you have certain goals that you're doing, and you know what you're doing, and you're checking along the way. And for a lot of treatments, it doesn't go on forever and ever and ever. And it's needed at the time. It's efficient, it doesn't waste. We get into this, supplies or energy or anything like that. And sometimes in behavioral health, unfortunately, we're not able to do, the extensive kind of work we are. We're just trying to get people through and get people some skills and get people linked up so they're doing better than they were before, and they're out of harm's way. And then it's got to be equitable. In other words, it's not based on socioeconomic status. It's not based on those kind of things. So AHRQ would say these are 6 domains of quality. Now, a different view of this is Anderson's work some years ago. And they talk about the 5 aspects of quality. So it's affordable, it's available, it's accessible, it's accommodating, and it's acceptable. So affordability means that people can pay for it. In other words, they have insurance to pay for it, they can pay for it out of pocket, or there's some means to pay for it. Available means that that people can get to it. That if they live in rural areas, they got telemedicine, they got broadband, they can get to it. If they live in the city, they can get to it. Those kind of things. So it's available. Accommodation means that it's provided in a way. Kind of 2 things here, but it's provided in a way. The provider's operation is organized in ways that meet the constraints and preferences of the client. So we don't think about this much, and particularly where we practice here in the Health Science Center. But we were pretty much 8 to 5 folks, but For a lot of folks, you'd need to be seeing folks in the afternoon. So a lot of places will have evening clinics because people are working. They can only come in, and even sometimes people have weekend clinics where they'll have Saturdays for families to come in or for individuals to come in because they're working during the week. So accommodation means it accommodates to the patient's needs, and then acceptable means that the folks are comfortable with it. That socially, culturally, racially, any of these other kind of ways is acceptable. So they feel that their social class, ethnicity is respected and they're welcome. So these guys came up with these 5 aspects of healthcare, old lessons learned. So these would say these are aspects of quality as well. Now then, we'll take a completely different look here out of the tobacco cessation treatment, but this would be another area of what we would call quality. So if you were doing substance abuse or you were doing tobacco cessation or you're trying to help people quit, you say, well, how am I going to do this? What is some evidence-based approach? And then this would be one that you might take a look at, and you might take a look at it and see how you adapt it to your practice. But let's say you're in a primary care setting or maybe in a mental health setting, and you don't usually think about tobacco as one of the kind of things you're going to be interested in. But here you'd say, well, you ask, and you document, for every patient. Do you smoke? And if you smoke, how much do you smoke and how long, just like you would do maybe with the substance abuse evaluation. And then you advise. So you let people know that this is not healthy, and you let them know something about what they need to do or what the options are to quit. And then you assess willingness. And based on their level of willingness, you assist, whether that's counseling or pharmacology or monitoring or any of those kind of things, and then you arrange for follow-up visits or telephone. This reminds you of an evidence-based approach that would come out of motivational interviewing, which is frames. And so we talk about that today. But I think the point I'm trying to make here is that, in terms of quality, you need to use evidence-based kinds of treatment so that you can look to the literature and that have been shown to be effective in some form or fashion, and more or less then you follow that protocol. So that's quality. Now, compliance, maybe you haven't had as much time or been exposed to it as much, but there's 7 components of a quality compliance program, and they've added an 8th one here recently, but we'll go over that in a second. But the first standard is in a compliance program that you have standards of conduct. And so if you're in a small practice, you might want to come up with some very simple statements, statements about conduct. And those things might have to do, they might reflect your ethical principles. If you're going to treat people with dignity and you're going to promote, benefits, and there's going to be non-malefits and those kind of things. And you might have something in standard conduct about what you do in terms of billing and financial arrangements. For your employees that work there, you might have a standard of conduct about confidentiality and privacy. For your providers, you might have the same thing. You might have something about if you do reimbursement for education, you might have a standard of policy about that. So all of these standards and policies are just going to be, so this is the way we agree to do business. This is kind of the standard we hold ourselves accountable to in these various areas, everything from seeing patients to business operations. And then if you're in a very small practice and you're the compliance officer, if you're in a small group, you may need to appoint a compliance officer, somebody who keeps up with compliance and those kind of things. But compliance questions in the compliance program, and particularly the next one, compliance education, is one of the kind of things that a compliance officer would look at. So even if you were in a small practice, it's just 2 or 3 providers and maybe 1 or 2 staff, you still might want to have some ongoing periodic education about HIPAA, or you might want to have something about privacy, or you might want to have something about how to shut down the computers, or you want to have something about those kind of things, so that you can show as a practice, as a provider, as a small group, that you're providing appropriate education to yourselves and to other people about your practice and your standards of conduct and what is involved in HIPAA, and what's involved in privacy, and what's involved in all those kind of things. Documentation would be another one. If you have very many practitioners, you probably, and particularly if you have very many practitioners of varied professions, it might be important to have some education on how to document correctly and how to bill correctly. And then the fourth one is monitoring and auditing. And so, you know, you work at a big place like Health Science Center, a big hospital or something like that, big, massive machinery that do all kinds of monitoring and auditing. But in a smaller practice, it might be that you just need some peer review that once a quarter, every other, you know, half a year, you know, on a semi-annual basis or something, you get together, exchange charts, you read the charts, and you just make sure that people are, you know, providing quality care, and you give each other kind of feedback, written feedback, or whatever that might be. If you're a little bit bigger practice and you have some people who work for you, you know, you might want to take a look at their charts, you know, a sample of charts, whether it be, you know, new charts, old charts, you know, young kids, it'd be older adults, it'd be, you know, whatever. And just take a look at the charts and make sure that people are documenting correctly. They're using the EMR, make sure they're using the EMR correctly. And you're not, I know some folks who had kind of small to medium-sized practices, didn't do very good monitoring and auditing, had a few providers that got way out of bounds, and it ended up costing them dearly. So monitoring and auditing is very important. Now, if you're doing billing, of course, you're doing electronic billing most likely. Some practices probably have the patients do their own billing, but a lot of us would have a service do. You know, you probably want to have the service do a monitor and edit, make sure that, you know, the billing codes are correct. I mean, if you see something like everybody's always billing the top code, upcoding, that could be a problem, or somebody's undercoding, or so you'd want to see a variation in codes in terms of 90837s or 90834s or 2s. Those kind of things. And then you need some kind of report. And, you know, you can, this could be very expensive and extensive, where you hire an accounting company to come in and kind of do an audit of your program, look at an accounting, look at everything, you have a professional come in and audit your charts and all those kind of things, or it can be very simple, and you can just have somebody from the outside come in and audit, look at your records, and just show that you're monitoring. You don't have to do the whole enchilada every year. 1 year you could take a look at HIPAA, 1 year you could take a look at evidence-based practices, 1 year you could take a look at something else. But if you ever get in any kind of trouble or you ever question, excuse me, the thing you want to be knowing is, what they want to look for is you have a compliance program that tries to make sure that you're practicing well, you're practicing ethically, and you're practicing evidence-based quality kinds of things. And so you need some kind of report or some kind of evidence that you've been doing that. 6, when you discover, and hopefully you don't, but when you discover that somebody's made mistakes, and they've billed without writing a note, or they've done other kind of things, then there needs to be some kind of repercussion, because when the feds come in or people come in and look at your program, if you know you've documented or you've shown that you know you've had some compliance, ethical billing, evidence-based kind of problems, and you haven't done anything about it, that doesn't look well for the practice or for the person who owns a practice. So you need some response, and prevention is education, and prevention is auditing, and prevention is editing, and prevention is giving feedback to people and letting them know how they're doing. Now, the latest thing that HHS, CMS, and OIG have added is called risk assessment. The practices show some evidence that they do a risk assessment, and by that they mean, you know, what are, you know, in the upcoming year, 2 years or whatever, what are my biggest risks? And so how do I mitigate those risks? And so for a lot of us, it would be technology. And so, you know, with HIPAA high tech and all that kind of stuff, it would be like, you know, the thing you could really get in trouble with is you got everything on a computer and you lose the computer, or the computer's stolen, and it's not encrypted properly, or those kind of things. And so that would obviously be kind of a risk area. For some practices, it might be disaster mitigation, you know, so your whole office gets flooded, everything goes down, and how are you going to recapture the records, and how are you going to reconstruct the records, and how are you going to, you know, get your practice up and running? So the 8th thing that compliance people are looking at is risk assessment and how you mitigate that. So for a compliance program, those are things you're looking at. Now, in terms of law, So this is criminal law. So, this is punishment for individuals who commit crimes and you get prosecuted. And it's because you did something to somebody else or you should have done something and you didn't. So usually these are acts of omission or commission for violating the law. So we see, like speeding, you're doing something you shouldn't do, so you got a ticket. Usually these are things you shouldn't have done. Murder, theft, fraud, all those kind of things, embezzlement and fraud, theft and embezzlement do happen in healthcare and even in behavioral healthcare. So we're pretty familiar with this. Civil law really has to do with the dispute between two individuals. So, and generally speaking, it's a case where, the former patient says you had a duty to perform for me and you failed to do that duty. And so I've been damaged, or you should have done something for me and you didn't do something for me. So I was harmed. And so you owe me some money as recompense for that. So we're mostly looking at malpractice here. And so a healthcare professional through either neglect, a neglectful act, or omission causes an injury to a patient. The negligence might be the result of an error in diagnosis, treatment, aftercare, healthcare. So the three things you look for are: one, did you have a duty? So do I have a duty? And those duties are to do things for people, and those duties are to not do things to people. So as professionals, as treatment care providers, we have a duty not to have sexual relationships with our patients. So if we did that, it would be hard to defend that. So we have a duty to protect them, to take care of them, not exploit them. We have a duty to provide evidence-based care. We have a duty to give informed consent, those kind of things. So there are things we have a duty to do, things we have a duty not to do. And somewhere along the way, there was this negligence or this failure to do it. So we did something we shouldn't have done, or we didn't do something that we should have done. And so there's this failure. And then there's this proximal cause. In other words, it's proximal. It's reasonable that the failure, that we had a duty, we failed, and it caused harm. So there has to be that connection. So they call it proximal cause. So there's some expectation that if you're having sexual relations with your patient, and your patient got upset, or your patient felt harmed, that if you hadn't had sex with her or him, then that probably wouldn't happen. So that'd be proximal cause. Proximal cause would be that I should have given you informed consent about how long this treatment was going to take and how much it's going to cost. And I failed to do that. And so now you're in the treatment and it's costing you a whole lot more money than you thought. And it's lasting a whole lot longer and it's causing more distress. So there's proximal cause that if I would have done proper informed consent, you might or might not have gotten involved in that treatment and you wouldn't be suffering the distress right now. So that's kind of the idea there for civil law. Now then, what we don't think about a lot, because we think about getting sued for malpractice, and hopefully we're not messing with criminal kinds of problems, but sometimes we forget about regulatory law. And so this is going to be, this really comes from the payers and the government, whether it's the state government or the federal government. And so these are the kind of things that have to do with, so legislatures say we're going to provide this service, or we're going to allow for these services to be paid for. Agency promulgates some rules about how to do that. They publish those in the Federal Register, and then they get disseminated from there. And then you're expected to abide by those rules in terms of what care you provide or how you bill for it, or those kind of things. And if you violate those rules, then you're susceptible to some penalties. So these are the big ones: False Claim Act, anti-kickback, START, physicians referral. That usually doesn't have. That's just for physicians. Criminal healthcare fraud and civil monetary penalties. So I'm going to show you, if I can, I'm going to show you this. This is something you ought to, if you're in any kind of practice or you're doing any kind of work, particularly if you have any, you ought to know it anyway. You ought to look at it anyway, but particularly if you own it or you have some stake in it, and you're responsible for other people's care. So this is the little booklet from, it's not that little, but it's relatively little. Medicare fraud abuse, prevent, detect, and report. So this is training. You can get a lot of training out here, but they're going to take a look at what is it, what's the difference between fraud and what's the difference between abuse? Now, this is Medicare, so usually Medicare puts out the standard and then Medicaid and everybody else kind of follows the standard. And then they're going to talk about, the big things that people get in trouble with. I just mentioned those is the False Claim Act, anti-kickback, Stark Law, criminal health care fraud statute, exclusion statute, and civil monetary penalties. And those can really add up. Let's look here though, because so this is a handy little chart here. So you're going to talk about, what is the difference between, abuse, mistakes, and fraud? So according to Medicare, you can see here that people make mistakes. These are results of error, incorrect coding, that it's not widespread and it's episodic. In other words, so sometimes, we saw the patient for 20 minutes and we coded it a 90337, which would be 50 minutes. And it's just kind of one of those things, we got the numbers backwards or whatever else. And when we when we look at the practice over the course of time, we don't see any pattern to this. And if it's the same provider, then there becomes a pattern. So everybody understands that people make mistakes. And insufficiencies these are like things that you do that are just wasteful. Well, we don't do this much in healthcare, but in behavioral healthcare, but sometimes everybody, gets lab or everybody gets this diagnostic, thing. Substance abuse, you might look at that. If everybody, I did read this in a compliance journal not too long ago. There was a drug, who was it? I think it was just, I think it's a rehab practice, but everybody got ordered the drug test. Everybody got ordered the drug test, regardless of what was going on. And so for the lab, that meant quite a bit of money. So that was probably more on the falling closer to fraud, but it would definitely be insufficiencies. If you do something for every patient, regardless, and then you might want to think about is that insufficiency. So there should be a justification for what what we're doing. And then the bending the rules. So this is where you get into abuse. So this is improper billing. This is like upcoding, those kind of things. And so we're, so you did something, but you're bending the rules. So that's basically what we're saying here is like, I did see the patient, but I saw him for, 20 minutes, but I billed for 53 minutes or those kind of things. Or I did so much testing, but I billed for even more testing or those kind of things. So this is where you did something, but you didn't bill for it correctly. Now then, fraud is intentional deception. And so this is where you're going to be, I didn't offer the service, but I billed for it anyway. And you see this a lot in behavioral health. When you read compliance problems, when you look at the OIG's website, people, not providing services, but billing. There was a practice up somewhere in the Northeast, I think a couple social workers, psychiatrists, billing for a lot of services that were not ever provided. So that's fraud. And these two kind of things can put you in jail. This will get you some corrective action. And what the OIG says is for big and small practices, if you have a mistake or a problem, you're somewhere up here, you wasted something, you got some errors, maybe even some abuse, that if they come in and you have a compliance program, then that mitigates the sanctions that you might receive. So that's kind of a good little description of those three things. Let's see what else. So let's take what time do we have? We got to. So anyway, so the False Claim Act, that actually came back in the Civil War under Lincoln because so many people were submitting bills to the government during the Civil War falsely, and so the False Claim Act came into place. Now, where that gets healthcare professionals is, let's say that you let your license lapse for a month or two, and so you were a LADC or social worker or LPC or psychologist, physician, nurse, or whatever you were, and you just hated to tell anybody because it's such an embarrassment. But anyway, it lapsed for a month or so, and you continued to see patients. So the False Claim Act would be for every patient you saw, for every note you wrote, that's a false claim act, and I think it's up to $1,000. And they call it treble damages. They can triple that. So let's just say you saw a couple hundred people over 2 months, let your license lapse a little bit. So every note you wrote for every patient, it represents a false claim act. That's about $1,000, and it'll triple that. So 300 patients, maybe you saw see a couple hundred, get up to 100,000 pretty quickly. We don't think much about anti-kickback, but anti-kickback can be anything that doesn't come across at fair market value. So somebody gives you a really good deal on some real estate in an office, and you're thinking, that's just too good to be true. It probably is. And so you need to think about the anti-kickback statute, because anything that you get is not at fair market value, or anything you get for remuneration for a referral would be considered a kickback. We don't worry too much about Stark unless you're working with physicians, and that's very complicated. If you're doing anything criminal activity, this is fraud. So this is like, I'm ordering durable medical equipment for patients that don't exist, or I'm taking a list of deceased patients with their social security numbers, and I'm ordering something for them. The exclusion statute means basically that you violated and you're going to be excluded from Medicare participation. And that's kind of like, a death sentence, because when you get excluded from Medicare, chances are you're going to get excluded from Medicaid. You're going to have a hard time getting privileges at any hospitals, and most private insurance guys will let you go. And anybody who receives Medicare or Medicaid can't hire somebody that's on the exclusion list. And so you're pretty well, that's, like I said, that's kind of the death penalty, like right before you go to jail. And civil monetary penalty is just a additional penalty they impose when you've done something bad. I think that can be trouble too. Anyway, this is a good little document for you to have, and it talks about relationship physicians, and most of that applies to us. Same thing with vendors. We don't deal with as many vendors, but from time to time you see that. Then they're going to break kind of out how you do it. They explain to you what CMS is, the Office of Inspector General, and what they do. And Office of Inspector General and CMS, they fund it, and it's the FBI, I believe, who actually does the investigation. And the reason is healthcare fraud is such a booming business for the feds, is that for every dollar they spend on healthcare investigations and healthcare compliance, they recoup about $7 or $8. So healthcare is a money maker for them, and other kinds of crime, other kinds of fraud, it's not near as lucrative for them. But they make a lot of money, and then they get to hang on to some of that money. So I've had a couple of presentations with former inspectors general, and they explain why healthcare fraud, healthcare compliance is so lucrative for them, because it's pretty easy for them to discover it. Once they discover it, they're large numbers, and then they get to keep some of that. So here we are back to this our little nut here. So we can see, hopefully from the presentation, that compliance is kind of the core of everything. And if we're practicing ethically, then there's a good chance our practice is going to be quality. And if our practice is quality, there's a good chance with a couple little program components, we're going to be compliant, and we're going to stay out of jail. And we're going to stay out of civil court too. So this is how it's kind of all nested. So got a few minutes for questions or comments or ideas.
I just like having the chance to look at everybody's codes of ethics. Is also, I mean, they have a lot of commonalities, but the one for drug and alcohol counselors is so small and simple compared to all the others. And so I was like, if you're following that one, you probably should look at some of the others, because it seems like it's not considering all those other aspects.
Well, I think that's true, Lenore. And I mean, on some of the big tickets, we're all doing kind of pretty much the same stuff. I mean, we don't misuse or abuse patients and those kind of things. But like I said, Some MSWs, may not do a lot in research, but then they may have a niche or something. They start doing more in research. And so it'd be good to look at ACA, it'd be good to look at APA just to see, well, how do I do research in terms of being ethical? And so different professions, have different little niches here and there where they've had to carve out some ethical principles or standards related to that little niche or that thing they do. So that's good. Some of them talk more about ethical standards in terms of relations to working with families and those kind of things. ACA talks particularly, I think, about grief and death and working with deceased and the patient's deceased. So there's some nice little things to look at when you're thinking about, or you run into an ethical kind of problem and you're wanting to figure out what to do next. You should look at some of the other standards. Good. Other questions or comments?
I was at a NASW board meeting last weekend, and we were looking at some of the statistics of how many social workers across the country, how many minority social workers were passing the licensure exams on the first try as comparison to other races.
Mm-hmm.
And so what we were trying to debate was what was there was a big disparity. And so we were trying to determine what was our ethical responsibility in having this information, and what should we do about it,
Mm-hmm.
ethically. And it got to be quite a debate,
I bet it did.
And, in the social work code of ethics, it talks very clearly about equitable practices and takes those kinds of issues into consideration. So
Mm-hmm.
it was quite a debate about what we should do having this information.
Good. Dr. Fink, you got any thoughts on substance abuse and psychologists and those kind of concerns about ethical or evidence-based practice you want to throw in?
Yeah, I do. I really appreciate the discussion today and how frequently you emphasize the use of evidence-based practices. I think that's an area in substance use treatment where still quite a bit of not evidence based practice is employed, and people, somewhat still feel okay with that. But the more we use evidence-based practice in substance use and seeking out trainings in our effective treatments and things like that, the better off we are as an overall profession.
I think that's true. And, I think when you're learning, it's obviously a good idea to learn the protocol. After you've learned the protocol, you got some leeway. But, if you're doing evidence-based treatment, that's, kind of protocol, I know where I'm going and I know what I'm doing and I know where the end point is. It's a lot harder, or it's not as easy to get off in some relational kind of thing with the patient that having consulted on those, having to deal with those, it's like 6 months later, we're off in this relational thing and somebody's getting disciplined. It's like, how'd you get there? Well, you didn't know where you were going in the first place, and you didn't have any guidelines for what you were doing day in and day out. So evidence-based, practice makes life much easier and safer.
Yeah. And your patients get better.
Oh, yeah.
I mean, your patients improve, just hugely in a very short period of time. Yeah.
That's good. We're about to wrap up. The other thing I just want to underscore again is, whether you're in a solo practice or whether you're in a big organization like we are, compliance gets done to us and we just try to keep up with it. But it is good to know what the rules are and have some understanding of what's going on. But if you're in a medium-sized, ABC clinic, or you're in an individual practice, paying attention to having some kind of compliance program where you're, dotting the I's, crossing the T's. You don't have to be expensive, but if you lose that computer, it's got everybody's name on it, and you got to turn them in, or you have some other kind of problem, and somebody comes to investigate, your life will just be so much better if you've had some kind of compliance program. You were going to say something, Administrator? Oh, I guess not. Okay. So I would just encourage people to think about that regardless of kind of size of practice you're in, is just think about how you can kind of hit those 7 things from time to time and document them just so, if somebody complains or somebody comes to see you, if you're running hospitals, that wasn't uncommon for somebody to complain or some agency to come see you, and just having done those things and having your documentation really makes your life, it's pretty stressful anyway, but it makes it less stressful because you got something to fall back on. But I don't know if there are any other thoughts on that or not. Okay, well, we're right up against the weekend, so I think I'll let everybody go. And we'll see you next week, and look forward to a VA talk, so veterans talk. So y'all have a good week.
Thank you,
Have a good
Dr.
weekend.
Rand.
You
Thanks,
bet.
Dr. Rand.
Thank you. You bet.